of low-cost surgical metallic clip placement for tumor localization in PIRADS 4-5 breast cancer patients undergoing neoadjuvant chemotherapy.
Assalamu alaikum, good afternoon, professors and colleagues. It gives me great pleasure to discuss today's lecture about assessment of low-cost surgical metallic clip placement for tumor localization in breast cancer patients undergoing neoadjuvant chemotherapy. First, breast malignancy is one of the commonest tumors affecting women, and the rate of breast cancer is increasing each year. The increasing incidence of cancer breast in women associated with increase in clinician and researchers' concern in improving diagnostic and therapeutic tools. And our hope today is that new targeted therapies are now available and being added in combination with the usual chemotherapy as neoadjuvant chemotherapy. That results that neoadjuvant chemotherapy is now considered the standard of care for breast cancer patients with operable or inoperable tumors. Now, neoadjuvant chemotherapy become a new challenging concept for surgeons and radiologists, as traumatic pathological complete response and high clinical response rate can be attained, which may hinder proper localization of any tumor tissue at a tumor bed and may hinder proper satisfactory reconstructive surgery. For these reasons, International Breast Cancer Specialist Panel in 2006 and 2010 announced the importance of molecular localization into the tumor bed. Here we have a diagram, sonar, ultrasound, and mammography images showing complete radiological resolution of breast lesion following neoadjuvant chemotherapy, and this pathologically proven as PCR after surgical excision. So في some indications of marker clip placement زي ما قلنا أول حاجة اللي هو for tumor localization. Second, the marker clip serves as a target for future preoperative wire localization. Third, clip placement allows confirmation that the lesion that underwent the biopsy was indeed the intended target. And finally, even in case of benign core biopsy result, the presence of clip can assure further images that the particular site has been biopsied before and avoid the need for additional intervention or workup. Some complications of metallic marking device, unintended movement at clip migration, pain at the side or arm or a neck, some instances of bleeding or infection. Some causes of clip migration, أول حاجة حاجة اسمها accordion effect. In mammography images, the breast may be compressed by mammography. When compression is released, the breast expands, and the clip can migrate in the direction of compression. Second cause, simple clip migration. The clip can migrate with a predominant fatty tissue of the breast within or outside the lesion. It's unrelated to breast compression. Third, clip flooding in hematoma, and hematoma may prevent any type of clip from adhering to the tissue, as it decreases the chance of good clip attachment. Fourth, clip displacement by a hematoma. The formation of hematoma at the biopsy site may cause significant mass effect and displace the clip. Finally, change in clip site after change in size or shape of the lesion, where the size and shape of the lesion where the clip is deployed may change after radiotherapy or chemotherapy, as this may be misinterpreted as a clip migration. So how to diagnose clip migration? By comparing the distance of the clip to the last mammography images on the three coordinate points, which is the distance from the nipple, from the skin, and from the muscle. Displacement is recorded if there is more than 1 centimeter difference in clip position. Since the first description of metallic clips in the late 90s, many different types of commercial breast markers are widely used. Although there are many types of clips, they are ribbon, coil, or ring markers, however, they are relatively expensive and represent quite a considerable economic burden. That encourages the researchers and physicians to search for other lower cost alternatives, as titanium consistent clips. And that titanium-based metallic clip markers are now can be safely used and placed within the tumor under image guidance, either mammography or sonography. So for assessment of surgical metallic clips, we conducted a prospective study on 45 female patients who were referred to the radiology department in Shams University hospitals and with pathologically proven malignant breast lesions and came for clip insertion before neoadjuvant chemotherapy. Our methodology can أول حاجة بنعمل proper assessment of sonography and pathology report of the patient, followed by ultrasound guided clip insertion. After clip insertion, sonomammography will be done for confirmation of size of the clip and the exclusion of any immediate complications as hematoma. After that, the patient will start neoadjuvant chemotherapy بتاعه. MRI breast with contrast was done 1 to 3 months after the start of neoadjuvant chemotherapy for assessment of lesion morphology, extension, degree of clip artifact, and effect of clip on image interpretation. Finally, follow-up sonography was done after receiving neoadjuvant chemotherapy for assessment of the surgical clip location, exclusion of any complication as clip migration حتى بعد MRI, and assessing the effect of a clip on image interpretation. Cost effectiveness was determined by calculating the cost of the surgical clip and compared to that of the commercial markers. هنا عندنا diagram to illustrate the technique of clip insertion. A clip inserted in the biopsy needle and style is used to deploy the clip inside the lesion, that followed by removal of the needle and the stylet. Our results show that regarding complications, only 2 patients, about 3.5%, showing evidence of clip displacement, as no other major complications were recorded, which proves that the clip insertion is highly significant complication-free procedure. Regarding ultrasound assessment, 43 clips, about 96.5, were easily visualized as a linear hyperechoic structure with or without clip artifact, and only 2 clips showed difficult in visualization by ultrasound. That's during the follow-up of neoadjuvant chemotherapy. ده عشان the tumor becomes smaller in size, and that hindered differentiating the tumor from the echogenic fat strands of the background of the breast. الechogenic clip بيبان أكتر في الhyperechoic nature بتاعت التيومر، فبيحصل differentiation بيبقى أحسن. Kochi et al. Compared between the surgical clip and commercial breast markers regarding ultrasound clip visibility and found that regarding surgical clips, about 91% of surgical clips show easy visuality by ultrasound, compared to commercial clips, which about 86.9%. And in cases where no residual lesion could be noted, he found that 88.2% of surgical clips were easy visualized, compared to only 80% of the commercial markers. يعني هنا حتى بعد ما الليجن اختفت الفيزابيلتي الاثنين قلت، بس الريلاتيف اللي لسه السيرجيكال كليب كان احسن من الكوميرشال ماركرز. Regarding MRI assessment, in our study in 45 patients, all the clips were MRI compatible, created a small signal void in MRI at while the primary malignancy was easily visualized. The surgical clips appeared as small signal void to this paramagnetic or susceptibility artifact. Regarding cost, surgical clips, total cost of the clip per patient were about 990 Egyptian pounds, is equivalent to $12 to $13, which is compared to commercial markers with average price range about $75 to $200, which average $90. So application of surgical clips saved about 1,135 Egyptian pounds per patient, which equivalent to 73 to 75 ultrasound per US dollars per clip, and confirmed that surgical clips are much lower cost compared to commercial markers. So a photo from a live case, we have a 40-year-old female patient with recently pathologically proven right invasive thyroid carcinoma and came for clip insertion. We have an MLO view and ultrasound images show a clip inside the lesion with no significant clip artifact interfering with image interpretation. MRI breast was done, T1 weighted images, T2 weighted images, and post-concert images all show a signal void due to inserted clip inside the center of proven malignant lesion with no difficult characterization of the lesion. After completing course of neoadjuvant chemotherapy, follow-up sonography was done. We have a CT view, ML view, and ultrasound images, which show regressive course according to the size of the lesion, and shows that the clip has migrated to the lateral end of the remaining part of the lesion. Yet the clip is seen in place in the mammography images. So, what's the cause of clip migration in this case, and why? Cause the clip migration هنا can change the size of the lesion, which is called total displacement. ده عشان the clip migration was only noted in ultrasound images, not in mammography images, which means that the lesion becomes smaller in size and the clip didn't move. So a take-home message, the use of breast markers are mandatory before neoadjuvant chemotherapy, and surgical clips can safely substitute the commercial markers as a tumor localization, that without disrupting radiological multimodality evaluation and with no significant complications and with a lower cost. Thank you. Thank you.
Thank you, Dr. Nourhan.